As a result, since it is a particle, it helps the idea that it can cause ionization or its movement, like, for example, the electron. When the electron moves, it moves in a way called tortuous motion, meaning random movement. It doesn't move in a straight line. For instance, if I told you that the gamma photon moves in a straight line, that's it. But the electron moves like this, like this. So, what we are trying to convey here is a sense of hesitation or contemplation. It's as if someone is pausing to think deeply about something important, weighing their options carefully before making a decision. This moment of reflection is crucial in understanding the context of the situation. The movement is referred to as tortuous motion, meaning it does not follow a specific straight line or distance, nor does it move along a defined pathway. Therefore, it can lose energy within a cell, such as a tumor cell, even if it travels large distances. This is when we talk about it being inside the body. However, outside the body, a longer distance is needed to stop beta particles, and different thicknesses of material are required. For example, alpha can be stopped by a piece of paper, while beta needs perspex or low density material. You cannot use beta particles. Why can't you use beta particles to stop it? You also cannot use LED to stop it. High density material, as you said, because if you use high density material, the beta particles will interact and produce something called Bremsstrahlung radiation. Remember the Bremsstrahlung that was produced with X-rays, where the electron coming from the cathode gets deflected by the nucleus and produces X-rays. The same thing can happen if you think about shielding the beta source with high density material. We need a different approval, like LED to stop it. You need something like LED to stop. No Bremsstrahlung. With whom? With LED. But you can use aluminum or perspex. Why LED? Because with LED, you are talking about very high density. There is a difference between aluminum and LED. The high density of LED has a high Z number. So you will increase the likelihood of interactions occurring, leading to Bremsstrahlung radiation. The Bremsstrahlung that is produced depends heavily on the Z number of the material or the absorber. There is also an equation that describes this and is calculated according to the Z number present. As we previously mentioned, in the context of radiation and particle physics, we have classifications such as low LED and high LED when it comes to neutrons. These neutrons are particularly noteworthy because they are considered to have high linear energy transfer, which is a significant characteristic in various scientific applications. However, the intriguing aspect of neutrons is that we don't often discuss them extensively in everyday contexts. This is primarily because some of their applications are not widely utilized or understood by the general public. For the process of absorption to effectively occur, it is essential that a boron source is present, or alternatively, a material that contains hydrogen atoms. This is due to the unique nature of neutrons. They possess the ability to pass through paper and other similar materials with relative ease. Even the sophisticated linear accelerators that are employed in advanced scientific research generate extremely high energies from X-rays, reaching impressive levels of about 15 million electron volts. These accelerators play a crucial role in various experimental and medical applications, highlighting the importance of understanding neutron behavior. For example, in X-ray and radiography, the maximum is 140 kV, while in nuclear medicine you can use FDG, which produces 5111 kV. When talking about linear accelerators used in radiotherapy, you can reach up to 15 million electron volts. This 15 million electron volts means neutron volts. Above 10 million neutron volts, there is an interaction between the X-ray and the concrete present in the X-ray room, resulting in neutrons from this interaction. These neutrons require specific materials. Sometimes graphite is used because it contains more hydrogen. Hydrogen can utilize neutrons. Now, they use these neutrons in therapy to obtain a neutron source or a specific material that emits a beam of neutrons, and the patient requires a material with a very high percentage of boron. Boron accumulates inside the tumor, and when neutrons interact with boron, ionization occurs, producing free radicals that can later lead to cell death in the tumor cells. This is part of the application, but I believe it is still not commonly known. Okay, is that clear? As you are aware, we talked about the topic and specifically mentioned that the event takes less than a second to occur, and after a second, it starts to happen. And just to reiterate, if this repair occurs, an attempt at death can happen within an hour to a day, as we discussed earlier. It is possible, depending on the situation, for example, if we are talking about cancer, it can take effect or it can take a doubling effect when it manifests. Here, for example, if you have a break in the DNA, specifically a DNA repair, what happens is that if you have the double strands of DNA, a break can occur in a single strand break. A double strand break means that both strands occur together. This is referred to as a double strand break. If there is only one double strand break, it is sufficient to potentially cause cell death, although the likelihood is lower. For instance, it can occur in the amino acid bases present in DNA. Or a double strand break can happen less frequently. Can you clarify that for me? Is it okay? The repair takes about 30 minutes. It takes longer than this. For the double strand break, which takes about 30 minutes, while the single strand break takes about 5 minutes. For repair, regarding the merging that occurs in the single strand break, as I mentioned, the double strand break is sufficient to cause cell death. Of course, this percentage increases with the increase in the dose received. If the dose is very high, you will find that double strand breaks start to occur, which will obviously increase the existing cell death or the probability of cell death occurring. We talked about the dosage in pregnancy, also the legislation from 2017 is really important. When Dr. Islam sent me a wonderful summary of the definitions related to this topic, I read about it and realized that today, as a radiologist, I need to understand what this means for me. I need to comprehend the regulations that organize work in radiation and the handling of radiation. So, what do I have in radiation? For example, I have various aspects to consider. Therefore, there must be regulations that address social organization. I am talking about the people connected to the patient or those who are exposed to the same medical exposure as the patient. For example, there could be a person who injected a patient with a radioactive substance, and there should be someone who stays with the patient to assist them. This person is exposed, and for me, there should be regulation of their medical exposure. There should be laws stating that this man should not be exposed to the dose There needs to be a statement about how much this person will be compensated. There should be a consideration for this person. And if I want to conduct an activity, the same idea applies if I want to do, or if this patient might undergo another examination, all the rules, all the regulations that pertain to the patient or relate to the patient. Or if I am conducting a research activity with volunteers, all of this falls under the umbrella of medical exposure. There are regulations concerning international regulations, or international regulation medical exposure regulations, or 12 medical exposure regulations. In 2017, regulations were established regarding patient safety and medical exposure. There are also 2 other categories concerning radiation workers and the public, as outlined in the IRR, which is related to the 2017 legislation. There are specific needs in the handling of radioactive materials, and the organization RSA 93 is concerned with storage. The organization RSA 9-3 is specifically related to the storage and disposal of radioactive materials. Now, regarding administration, I have a patient coming to the nuclear medicine department who will start receiving a radioactive substance. How is this radioactive material prepared? How is the dose determined? What should I do in case of wrong administration? And how should I respond if an incident occurs, such as if a patient receives a dose and dies after taking it? How will the radioactive material be buried? How was it handled? If it is oxidizing or if it is pregnant, we need to address everything related to the administration of radioactive substances. Regarding the radioactive material, how is it stored? After I have used it, what happens next? When it becomes waste, should I discard it as normal waste or treat it as irregular waste? I need to measure its exposure at a certain level, and then when it reaches background levels, I can start disposing of it. My radioactive material comes from the nuclear reactor in another country, and it is transported to my country. How is it transported? It is transported by plane, and its storage and shielding are important. When it arrives in my country, how is it measured? It is measured on the surface at a distance of 1 meter, and it should not exceed a certain dose. I label it so that if it gets mixed up for any reason, it is clear that it is radioactive material and must be marked accordingly. All the information that pertains to its animals, which reflects its specific type, its waste, and the specific numbers associated with it, should be considered according to future prospects. Therefore, there must be an impact because the subject is not easy. It is not just about doing the work and the examination and then finishing the matter. There is an impact on everything. And all of this is, of course, monitored by the national organizations that exist, as well as by international organizations like the IAEA. National activities across the country remain in need of being linked to the correct system or regulatory framework. For example, the IAEA oversees these laws and monitors them. I also have a very important role in the institution itself, whether it is the hospital or the radiology center, as it is responsible for applying these regulations, monitoring them, and ensuring their implementation. As we will see later, everyone has a job description or a role in this matter. The practitioner has a role, the referrer has a role, and the radiation worker has a role. There is also something called the radiation safety advisor and the radiation safety supervisor. The advisor has a specific role, and the supervisor has a specific role, and the employer itself has a specific role as well. As we mentioned, the announcing radiation medical exposure regulations. To collapse the range, this includes all the medical exposures we were talking about. If we talk about the idea that I have 3 things, I have the dose limit, I have justification, and I have optimization. We said that these 3 principles exist. According to the ICRP, I have the dose limit and I have the protection, which is the ICRP. We previously discussed in detail justification, where I provide justification for my case or the upcoming situation in a comprehensive manner, and optimization, which is the significant reduction of existing parameters in the context of medical procedures. The dose limit, we said, does not be applicable to the patient present, but is replaced by the concept of dose reference level in this context. We talked about dose reference levels, which are based on statistical analysis or surveys conducted. These surveys begin the process of recording specific examinations and begin to assess where my patient doses are positioned. The regulations in the analyzing or the ARM regulations in the regulatory framework include justification and optimization in clinical audits, which comprise of training, research exposure, and medical legal exposure in various aspects regarding incidents that may occur, of course, unintentionally for patients, such as a patient being exposed to a dose. They should not have been or facing a specific issue. Is it okay? There are also things here that allow for the inclusion of items related to medical exposure or skin. Well, if there are now two types of events that can happen. There is a specific incident where patients are exposed to an increased dose or are scanned or examined incorrectly. This means there is an error, such as when a patient comes in for a CT chest and instead receives a CT pelvis. In this case, or if there is an error related to the scanning, all of this falls under the regulations of medical exposure. Now, if you have, for example, an issue with the X-ray tube itself or the equipment, and an accident occurs for this patient due to this problem being related to the equipment failure, then is this included in these regulations? They would say no, it would not be included in the ionizing radiation medical exposure regulations, but it would be covered under IRR 99. So, what matters to us? What do you need to understand about all the laws? What are the things that are included in it, and what are the things that are not included in it? All the regulatory matters. What are the things that are included in it, and what are the things that are not included in it? These are the things that aren't included in it. And what are the things that are included in it? Who is responsible for the patient and who is responsible for the worker? There is a principle called ALARP. We always talk about as low as reasonably achievable. So what does ALARP mean? What is the meaning of the term ALARP, which is as low as reasonably achievable? In simple terms, as we talk, the more you can reduce the radiation dose, the more you can minimize the exposure that exists. Well, for example, we used to use it more, or it would be, now I am working in a place where I reduce the time I am exposed to, I keep a greater distance, and it becomes, for example, my exposure is less, so I called it that at that time. Okay, if it became straight angles, but in the case where you are talking about the patient, the term as low as reasonably practical means that at that time, during the practice itself or your work with the patient, you should try to reduce the exposure or the risk or the exposure that will occur concerning the patient or in their practice as much as you can. This is the meaning of the term as low as reasonably practical. The topic of the diagnostic reference level involves something called the dose reference level. For example, I have certain examinations. Let's take X-rays as an example. In X-rays, I have areas like the chest, anterior chest, posterior chest, cervical spine, and examinations like the knee and lumbar spine. There are many examinations. Now, you will find something in the machine called entrance surface dose and dose area product. What does this mean? You will find a term here called ASD and dose area product. Here is the X ratio, and here is my patient. Now, there are things that represent the dose at a certain point, which I call entrance surface dose. This point represents the surface of the patient's body, meaning the dose at a certain point at the patient's surface. This dose is called ESD. At this dose, so this dose is automatic. When you enter the key in the milliampere and input your parameters, it is automatically measured. This dose is per certain area, meaning that right now, for example, I have a specific field and view. This field and view have a certain area, and the dose multiplied by that area is called the dose area product. These two quantities represent the dose for the patient. Now, if I have a specific examination, and this examination is done, I will find something to assess. For example, I will take 30 patients from the abdomen, and each one of them will have a certain value. Then I will calculate something called the mode, ESD, and the dose area product. Now, let me calculate something called the mode. There are statistical calculations you can perform, including calculating something called the 75 percentile, which is 75% of the mortality value of your data. This is considered important. Now, you have cases with low doses and cases with high doses, and you have determined your diagnostic reference level, DRL. For example, your DRL is considered to be 75% of your mode value. I refer to this mode value as the investigation level. What does investigation level mean? It means I have this value or this figure that is supposed to... I will conduct a survey. I now know that my diagnostic reference level, DRL, is this specific value. Okay, and the value for the other one is this specific value. Now I want to reduce this value. So what should I do? I should start by slightly improving the quality. I will use a certain technique to enhance my quality a bit. I will start to reduce what technique will I use, and I will conduct a second survey on the same new parameters and collect new data, and my new diagnostic reference level, DRL, will be established. This DRL will be in place for 3 years, and for me, this DRL will be valid. After 3 years, I will start this survey again and check on my cases to see how the operators and the staff adhered to the parameters, and whether the doses are still within my limit or have exceeded it. If it turns out that your limit has increased, then at that time I need to conduct an investigation into why these cases have increased. Could the cases increase? Yes, they could, but there must be a reason for the increase in doses. Now I find that I can perform another optimization and reduce the reference dose level again, create a new reference dose level, and work on it. The reference dose level can be established at the level of the radiology center, meaning a place or institution, or it can be done at a national level across the entire country, or it can be established among multiple hospitals. The difficulty with the dose reference level is not actually in X-ray or CT. In CT, I have two quantities. One is called CT dose index volume, CTDI volume, and the other is called dose length product, DLP. The CT dose index volume represents the dose in a specific slice or section, while the dose length product represents the dose or total dose in the total scan or total scan length. I also take these dose quantities and start working with them. Now, can I use the effective dose in this context? They say, no, you don't work with the effective dose. What I need are the dose quantities that come directly from the machine itself, which are what you will work with and what you will use to calculate your diagnostic reference level, DRL, whether it is the dose exposure product, DEP, and the air Kerma standard dose, ASD, in radiography, or the CTDI volume or DLP in CT, for example, a specific CTDI volume and DLP for a CT chest. These are available on the summary page of the machines. The issue is that the DLP depends on the type of examination which it represents.